Okay, looks like we've all joined. So good evening, welcome to our webinar on gallbladder problems and treatment. Presenting this evening is Mr. Ahmed Hamouda, our consultant surgeon at Benenden Hospital. This presentation will be followed by a question and answer session. So if you'd like to ask a question during or after the presentation, you can do so by using the Q&A icon that's at the bottom of your screen. And you can do so with or without giving your name. But please be aware that the session is being recorded, so if you do provide your name, that will come up in the recording. And if you'd like to book a consultation afterwards, we'll provide the contact details at the end of the session. I'll now hand over to you, Mr. Hamouda.
Thank you very much. Thanks, Ollie. And thank you very much for joining us today to talk about gallbladder problems. Really a very interesting topic, but a very common condition that a lot of people struggle and suffer with. So I will take you through some of the points included in this session, which is what are the common problems that can happen with gallstones and gallbladders? What are the symptoms? So how you present, basically, what causes them, and then the consultation that we have here at Benenden and what we do to diagnose the problem. Moving on then to management, how we treat it, what to expect with your journey through the hospital, what to expect with recovery, living without your gallbladder, and how to arrange your treatment, followed by a Q&A session. So let's start off. The gallbladder is a pouch that sits underneath the liver. So it's attached to the undersurface of the liver. It is basically connected to a channel that you can see here, the very fine channel. Here is the main bile duct, and that runs from the liver all the way down to the bowel. It takes bile secreted by the liver into the bowel, and that has a digestive function. So bile is really a digestive juice. It helps break down fat particles and rich food. So what the gallbladder does is during the day, it stores bile, and then when you have a meal, it then gets certain hormone signals to contract and push all the bile that's in it into the bowel, so that then you have that digestive capacity to break down the fat that's in your meal. So the problems that can happen are obviously forming stones inside the pouch, and that will be a precipitation of cholesterol to first of all crystallize and then become bigger and larger over a period of time. If you have stones on their own, we tend to call it cholelithiasis. Difficult word, you don't need to remember it. But basically gallstones, and the condition that comes with it, or the pain that comes with gallstones, is called biliary colic. So colic related to the gallbladder and gallstones. If the gallbladder becomes inflamed, then that goes into something called cholecystitis, which is the pathological word for inflammation. If it becomes really badly inflamed and it goes gangrenous, then it can perforate, and that is a medical emergency. So you have to go straight into your local A&E and have that sorted out by drains and operation, antibiotics and fluids. And then the stones that are in the gallbladder can move out of the gallbladder and into the bile duct. And that migration into the bile duct creates something called bile duct stones, or what we call choledocholithiasis. Choledocho meaning the bile duct, lithiasis is stones. If that happens, then you can have jaundice, where eyes go yellow, urine turns dark, inflammation of the pancreas, or inflammation of the actual bile duct itself, and that's cholangitis. These three terms only relate to stones that have passed into the bile duct and represent a much more complex presentation of gallstones. So this is something that you would need to go into hospital A&E for and be treated quite aggressively. So the gallstones themselves, as mentioned previously, sit inside the gallbladder. They start off as very small crystals of cholesterol, and they precipitate, creating larger stones. Some people have just one single very large stone. Some people have what we call sludge or mud, and that's in the early process of precipitation. And some people have multiple gallstones, multiple small gallstones. They're very nice, they're facetted, they sit together, and they have sort of very smooth faces facing each other. And in that case, obviously, you can get symptoms with them. In the majority of cases, we find out about gallstones because you've had a scan for something else. So You go into hospital and you have some pain on the left-hand side, for example. You have diverticular disease, but they do a scan. Anyway, they pick up that your gallbladder, which sits on the right, has some gallstones. You've never had any symptoms with it. We tend not to treat those. We just leave them well alone. It is a very common condition. So 1 in 10 adults in the UK is estimated to have gallstones. And only a very small proportion of that group of people develop symptoms. So what are the symptoms of gallstones? So you can have typical symptoms or atypical symptoms. Now, the typical symptoms are classically bloating and crampy tummy pain with after you've had a meal, a rich, big meal, usually with discomfort and pain under the rib cage on the right-hand side, going into your back and sometimes going up into your shoulder. And that is the pain of biliary colic. It will last a few hours and then it dissipates on its own. It can be helped by taking painkillers such as paracetamol or buscopan, which is a spasmolytic. It breaks down spasms and colics. And that is called biliary colic. If it becomes a bit more serious and it turns into an infection with inflammation of your gallbladder, then the pain can become much more persistent with a high temperature. And if we do a blood test, so you come into hospital and we do a blood test, we find that you have raised inflammatory markers. That's things like the white cell count, the CRP, and that's when we diagnose that your gallbladder has become inflamed. It can also look quite inflamed on an ultrasound scan with a thick wall or any collections around it and in the liver. So that again can lead to us diagnosing it as cholecystitis rather than biliary colic. So we said about the cause of gallstones, it's a high level of cholesterol in the bile, precipitating and causing crystallization followed by stone formation. We find that the people most at risk of developing gallstones are carrying a bit extra weight or obese, but also, interestingly enough, people who tend to try and lose weight either by crash dieting several times or having a procedure, an intervention to lose weight, such as a sleeve or a gastric band or a bypass, can also develop gallstones. So what's happening there is that the fat that's being mobilized as a result of the weight loss creates a higher level of cholesterol in the bile, and that in itself will cause the gallstones. Females are particularly prone to it, and especially fertile females, maybe something to do with hormonal change, usually above the age of 40 rather than younger, but young people can also develop gallstones, especially if they're pigment stones. So people who have certain blood diseases where the red blood cells are broken down, those pigments can then travel in the bloodstream, go into the bile, and again, do the same process of crystallization, precipitation, and stone formation. So just to go back and mention the atypical symptoms, because I did say about typical and atypical. So the typical was the one that I talked about with the right-sided tummy pain going to the shoulder. Sometimes people come and see us because they've had chest pain, for example, or they've had some mid-tummy pain going to the left side. And that can be the pain caused by gallstone pancreatitis, for example, or it could be associated with reflux and heartburn, because those two conditions, gallstones and reflux, can occur together. So when that is the case and it's atypical, then you really need to, first of all, see the doctor, but try and get seen by a specialist to assess your condition. I have a lot of patients who come into clinic to see me, and what they've been through is that they've developed chest pain, and initially the thoughts were this is cardiac, something to do with their heart. They've had all of the tests on their heart, and the tests are absolutely fine, nothing wrong with the heart. But then they have an ultrasound scan because their GP requests it, or they go into hospital and they think, well, let's scan your tummy, find out what's going on. And lo and behold, you have gallstones, and that can be the presentation, the atypical pain that comes from your gallbladder having stones. So, as I mentioned, the gold standard test for a gallbladder condition is an ultrasound scan on the tummy. It can also be diagnosed through a CT scan or an MRI scan, better known as an MRCP, which is a very specific MRI done on the gallbladder and the liver, and it picks up stones both in the gallbladder but also in the bile duct. So sometimes you'll come and see us at the hospital and we'll look at your ultrasound scan, but we think, well, you know what? You've had jaundice in the past, or you've had deranged liver functions. There is some reason for us to suspect there might be a stone sitting in the common bile duct, and that's when we'll also ask for an MRCP before your surgery. Because if you were to have a stone sitting in the colon bile duct, before surgery, that stone needs to be cleared by doing a camera down this way to fish that stone out before you have your surgery. If it was left in there, then you're more likely to have complications such as cholangitis, pancreatitis after you've had your gallbladder operation. And that is not favorable. It's always best to clear the stone first before you have your gallbladder operation. So we talk about obviously diagnosis with an ultrasound scan, with blood tests if need be, if an MRCP if required, an ERCP, which is the camera if need be, and then we talk about surgery itself. So surgery is keyhole. It's called a laparoscopic cholecystectomy. Normally surgeons will use 4 cuts, some people use 3 cuts. And as you can see there, there's 4 cuts there, a camera through one of the holes, in one of the tunnels, and then 3 other holes for instruments to hold the gallbladder, dissect and peel it away from the liver, cut away the bile duct, the cystic duct and the cystic artery that go into it from the main channels, and then put it into a bag and take it out through the belly button. It is a straightforward and simple procedure to perform, but it also has a risk of complications. Complications usually arise as a result of previous inflammation leading to quite heavy adhesions around the gallbladder. So it can stick to the liver, it can stick to the omentum, which is the bit of fat that we have inside our tummy that protects us. Or it can stick even worse to the bile duct or to the bowel that's next to it. And if it does, and it creates a little opening, a channel into those structures, then it becomes a much more difficult and complex procedure. And of course, the risk of conversion to an open cut is much higher. But if you do have to have an open cut, it means your recovery is much longer. You probably will need to have drains put in and left for a period of time. And I would have to be honest with you, at the Benenden Hospital, that's not perhaps the best outcome from having a gallbladder procedure. So sometimes we'll say, you know what, we think that your procedure should probably be done in a hospital that has a lot of backup facilities to allow for your gallbladder operation to be performed safely. Or I will sometimes say to people, you know, I will go in, and part of your consent is that if I find it's very difficult to do for any reason, or it's stuck to a vital structure around it, then I will abandon the procedure, and we think about obviously your safety first and more paramount, and we think about how we deal with this at a later stage. After you've had your surgery, the gallbladder no longer stores bile because it's gone, so bile will trickle through the main channel of the bile duct into the bowel, and that can lead to you being a bit on the loose side with stools for a few weeks after surgery until your bowel gets readjusted to the fact that there is a continuous flow of bile going into it, and it's no longer being kept and stored in the pouch. So it's a general anesthetic, we know that. We do small cuts, we said 4 or 3. We use instruments, and keyhole surgery is extremely beneficial. It has really changed the way we operate. It's changed the way surgery has been done over the last 15, 20 years. And I think that the recovery time is much quicker. This operation with open surgery meant that you spent 4 or 5 nights in hospital. It took about 4 to 5 weeks to recover, and probably didn't feel normal up until 3 or 4 months later. With keyhole surgery, you're in and out on the day. You're back to work if you can work from home in the first few days. You shouldn't really be driving for 2 weeks, but generally you feel fit and healthy and well in yourself, and usually at 6 weeks you're completely back to normal. So with our, as I was mentioning before, because of the keyhole nature of this particular type of surgery, it is expected to be a day case procedure. So you're in and out on the day. Prior to you coming in, the pre-assessment nurses will contact you. They will go through any fasting instructions, what you should bring, and your admission time. But also there's going to be a pre-assessment appointment where you come and see them in hospital to have your bloods taken, to have any swabs done, and to make sure that they're quite happy with your medical history, that there's no conditions that will need extra support, or that you're eligible to have it done at Benenden. Any of you that have been to our hospital know that it's a really lovely site. It's a brand new hospital that's only been in operation for the last 3 or 4 years. All the rooms are individual. You have your own ensuite facilities. We expect you to be able to leave the hospital the same day. After the operation, you will come out of theatre into the recovery area. You spend about half an hour to an hour there until you're ready to go back to your room. A nurse will come down and pick you up, obviously with the bed, and then they'll look after you on the wards, get you to eat and drink, get out of bed, go into the bathroom, check that everything is absolutely fine, and then arrange for you to go home. And usually they will contact your next of kin or carers to arrange for them to come and pick you up. So recovery, most people leave the hospital the same day. If there's any issues with pain, for example, retention of urine, needing a catheter, anything like that, then of course we keep you in overnight. After 2 weeks, you're returning to most of your usual activities. You shouldn't be driving for this period of time. And usually at 6 weeks, we say you're back to normal. And that means going back to the gym. It means going and doing your horse riding, your golfing, anything that you would like to do. So without your gallbladder, is there a big difference? Well, yes, to a certain extent, you can't digest a big, rich meal all at once. Remember when I said about digestive capacity? So you haven't got the digestive capacity to have a big fry up. If you do, then it won't kill you, but what will happen is you'll get a lot of bloating, crampy tummy pain. You will feel indigestion, proper indigestion, because your food is sitting there and it can't go anywhere until it gets broken down. So it will take a bit of time and then it will obviously pass. It is wise to, when you've had the surgery, to stick to a generally, not a completely no-fat diet, but a generally, Mediterranean healthy diet with as low fat as you can, or maybe in small amounts rather than having one big fry up. Any type of surgery has risks. So the common risks of surgery is you can react to the anesthetic, bleeding, infection, clots going up to your lungs from your legs, or conversion to an open cut. So with specifically a gallbladder operation, because the gallbladder comes off the main channel like a leaf off a stem, there is the risk of injury to that main channel. We said it was the bile duct or the common bile duct. There is probably a less than 1.5% chance of that happening. If it does happen, however, it can lead to peritonitis and sepsis, and you may need another operation to fix it. So that's an important one to mention, and obviously an important one to know about. If you want to have treatment for your gallstones, then of course you can come and see us at the hospital. You need to speak to the private patient team and book a consultation. And of course, we've got both private medical insurance, but self-pay members coming through, as well as society members and choosing book. So having said that, I will hand over again to Ollie, who's going to talk you through the Q&A session.
Thank you, Ahmed. We have had some questions come through. The first one is a patient asks, what would be the risks of delaying surgery to remove the gallstones?
Right. So it's really important when I said initially about biliary colic, and I differentiated biliary colic from cholecystitis. If you have biliary colic, which means you get sore and uncomfortable and bloated every time you have a rich meal, then to a certain extent you can live with the condition as long as you're sticking to a low-fat diet. And when I say live with the condition, I meant, waiting until you have your turn to have surgery. So eventually having surgery to rid you of the discomfort that you have. But if you have cholecystitis, inflammation, quite bad inflammation that's led to persistent pain, temperature, or having deranged liver functions because there's been stones that have passed into the bile duct, then the recommendation is to have your surgery as soon as possible. So it's a much quicker pathway to have your surgery. So it really depends on what the condition of your gallbladder and your gallstones is.
Great, thanks, Ahmed. Another patient has asked that they've been told their gallbladder is stuck to their liver and bowel. They've had a failed black hole surgery last year, and they've had a recent episode of gallstone pancreatitis. They're due to have an MRCP next week, and they're asking what would be their options for treatment.
Well, and I mentioned this in my talk, and I said that there can be presentations of gallstones that are quite complex. If you have a connection to surrounding structures, your gallbladder is connected to surrounding structures, or there's been a pancreatitis, which has increased the amount of inflammation inside the stomach, then there is a chance that keyhole surgery is not going to be successful and that you will need an open operation. And that open operation is best performed in a hospital that has all the necessary backup facilities. So a possibility to put you into high dependency or intensive care, a possibility to do X-rays and CT scans throughout the 24 hours of the day. So having, radiology cover, a possibility of inserting drains under radiological cover, a hospital that can do an ERCP, which is a camera down this way to fish any stones out through the bottom end of the bile duct. And that normally is within the context of an NHS hospital. So we are very happy to help in looking at your condition, doing the scans, because we can do the diagnostics. But there is a possibility, if that is the complexity of your case, we will at the end of the day say it's safer for you to have it done at your local hospital.
Great, thanks, Ahmed. This next person has asked, would they need to have scans after the procedure just to check that it's all gone okay?
It is not required, and it's not really standard for us to do any scans after the procedure. Remember, we go in with camera, a keyhole operation. We have seen everything. At the end of the operation, we check and make sure everything's all right. We look at the liver, look at all the structures around it. There is no suspicion of us requiring, any further scans. The only indication for a scan would be if you had persistent temperatures, for example, or persistent tummy pain that didn't go away 2 or 3 weeks later. And if we suspected the collection, then we would ask you to come back and have a scan, an ultrasound scan, to diagnose the problem. But as a standard, we do not use scans at all after surgery.
Great, thank you. This next person has asked that they've had an umbilical hernia in the past, and they have mesh over the belly button, in fact 2 meshes. What would be the procedure to remove the gallbladder in this scenario?
Yes, so more difficult because, of course, piercing a hole through the mesh with keyhole surgery can be quite difficult. It is, however, not impossible. And I've operated on several people who've had mesh before. Unfortunately, because you're puncturing a hole through that mesh, the risk of developing another hernia in the future is a possibility. So that's something that you will have to consent to. Sometimes we can be quite smart and clever with where we put our tunnels, our keyholes. So if the mesh is above, we try and go below the belly button. If the mesh is below the belly button, we try and go above it. But if it's just across the middle of it and there's no way of doing anything apart from going through it, then that's what we do. And you just have to contend with the fact that you may develop another hernia in the future that may need to be treated.
Thank you. The next person has asked, can you treat a gallbladder without surgery?
So remember, we talked about people having gallstones without any symptoms. So again, you've got this large group of people who have gallstones, either diagnosed on scans or haven't at all been diagnosed, who are sitting there with no symptoms, and that's absolutely fine. We don't need to do anything about it at all. And then there's people who've had biliary colic, so symptoms of pain whenever they've had a rich meal, they've come to see us. It's only happened once in the last, say, year, maybe twice in 2 or 3 years. And we have a discussion in clinic, and we talk about it. And if they stick to a low-fat diet and they're doing quite well, then there's no real indication for us to take out the gallbladder. And that's an agreement between doctor and patient. However, if there is complications, as I said before, cholecystitis, or you're a stone passer and you've passed stones into bile duct, then it usually is an indication that you will need to have surgery.
Great, thank you. This next patient says that they were diagnosed with a large gallstone at the beginning of the year, and they had symptoms of vomiting, pain in the back and abdomen. However, the pain has stopped since January and they have no symptoms. Should they leave it and they feel normal, but they're worried about gallbladder cancer?
So there is a fallacy about gallbladder cancer, and I think it's been blown out of proportion slightly. Again, it might be internet, it might be social media, but gallstones in themselves do not cause gallbladder cancer. So, in my book, if you leave your gallstone, that is not putting you at any extra risk. There are people who are diagnosed with gallbladder cancer who have gallstones, and that's unfortunate. but there is no correlation. You might find a correlation between gallbladder polyps, for example, and an incidence of gallbladder cancer, but not necessarily stones. So I would, in this case, just again consult and say, you know, it looks like you're doing quite well with a low-fat diet. There's no real urgency or indication to take out your gallbladder. Leave it a bit longer, see how you do in the next 6 months to a year. If you get another severe attack, then come back and see us, and we can obviously deal with it.
Great, thank you. This next patient asks, they had a radial nephrectomy and have also had multiple gallstones. Their consultant will not operate due to their previous surgery. Would there be any other options for them?
So radical nephrectomy, if it's on the right side, a big scar going across there, then of course it can make surgery quite complex to take out your gallbladder. If it's on the left side, less so of a problem. You've obviously seen someone and they've said, no, we don't want to do it for you. But again, remember that there is multiple options. There's the option of keyhole surgery. And if that doesn't work, there's the option of open surgery to take out your gallbladder. So there's always going to be an option, even if you've had previous surgery. And it really depends, again, on your symptoms, on how badly inflamed the gallbladder is, because, you know, if it needs to come out, it will need to come out, even with an open operation. It's just important that you have that operation in a place which can deal with you safely. And so, again, going back to what I said before, at the Benenden, it's not the best place to have an open procedure on your gallbladder.
Great, thank you. This next patient says that they had raised levels of ALT and AST after a flare-up of pain, and several blood tests later, over a period of 5 weeks, they've returned to normal. They do have a gallstone, and they're wondering, could this have been caused by the gallstone?
Again, it's you know, difficult to say, but we know that deranged LFTs normally happen when there's severe inflammation of the gallbladder, affecting the liver and causing inflammation of that area as well, and perhaps a pericholecystic collection, which means a collection around the gallbladder, or if the stones have passed. So you say just one stone, and I just wonder if there was another stone that may have passed and caused the raised liver functions. Again, it's important to have a consultation, important to have an MRCP to exonerate the common bile duct and look at the condition, and then try as best as we can to understand a bit more about whether the stones are causing a problem. If they are, and it looks like they're the culprit, then yes, you should have your gallbladder taken out.
Great, thank you. This next patient says that they've got exceptionally low cholesterol. Why would they get gallstones in this case?
I don't know about exceptionally low cholesterol. I mean, presumably the blood tests have been done and the cholesterol was looked at for one reason or the other. If it's in the lower range, it doesn't necessarily mean that it's always been low. It could have risen at some point. The other thing to remember is that gallstones aren't necessarily just cholesterol stones. You may recall when I did my presentation, I was talking about pigment stones, but there's also calcium stones. So there's quite a few things that can cause stones, and cholesterol is only one of them. Maybe the most important one of them, but not necessarily the only reason for gallstones. I tend to say that gallstones, if they're there, they're there. It doesn't really matter what's caused them. You just need to deal with them, basically.
Okay, thank you. Another person asks, their gallbladder has been diagnosed as permanently closed with gallstones. What would be the causes and the solution for that?
I think what you're referring to is a gallbladder packed full of stones, so there's hardly any space for any bile to go into it. And that's quite common. So you'll find that the gallbladder is completely packed full of stones. So by definition, it is non-functioning. In other words, it's not storing bile anymore. And essentially what's happened is that bile is continuously trickling from the liver into the bowel, just as if you didn't have a gallbladder. So if you do have symptoms and you're uncomfortable with your gallstones, then that should be an indication for you to have them taken out in that condition.
Great, thank you. Another patient asked, they had cholecystitis and they have a CBD stone, and they're due to have a 10 centimeter stent removed. What factors would decide if their bladder removal is necessary?
Yes, so going back again to my presentation, if you've had a condition where your gallstones have slipped and gone into the main channel, now whether they've been dealt with by an ERCP, which has just nicked the bottom, that's called a sphincterotomy. They nick the bottom of the duct, there's a muscle there, and if they open it, that's called a sphincterotomy. That's just to allow any further stones to pass through if they slip into the bile duct without causing an obstruction. Or they haven't been able to remove the stone, so they put a stent, a tube into the bile duct to create a channel that can drain bile and avoiding an obstruction by that stone. But if you've had any of those conditions where a stone has slipped through, then by definition, you need to have your gallbladder taken out if it's possible and feasible. The only thing that would stop it is if your health condition is so you're very unwell to the point where you can't have a general anesthetic and surgery on your gallbladder, in which case we look at other options.
Great, thank you. Another person has said that they've heard that there's an option to have the neck of the gallbladder widened so that the stones could pass through. What would be your opinion of this?
Yeah, so there's some of our X-ray doctors are very specialist in going in to the bile duct from the bottom end, and then using a stent, which we've just alluded to in our previous question, a tube. But instead of the tube going into the bile duct, it also goes up up into the bile duct and then into the cystic duct, which is the very small channel that leads into the gallbladder. And again, I think that some people do use it to try and drain the gallbladder when there's been pus in the gallbladder, for example, or a severe inflammation, to allow the whole thing to settle down. I would have to say that the people that specialize in putting those tubes or widening the cystic duct are very, very, very a small cohort, and it's possibly not something that you'll find in your local hospital. So by definition, my choice would be in this case is to give antibiotics, treat the inflammation, settle it all down, and then go in at the optimal time and do an operation rather than widen the cystic duct.
Great, thank you. Another patient asks, they have a 23mm stone. Would that be able to be treated with medicine or something like a laser?
Yes, so again, one of those things that I find a lot of people coming into consultation with me talk about is melting or dissolving stones. It's all really Chinese medicine that's on the internet, and I would not ever recommend that anybody try it. I would not recommend a laser or zapping gallstones. If you think about it, what's happening there is you're trying to make the gallstones smaller in size. So by definition, they are going to be easier to slip through into the main channel. And we said that that was one of the dangerous presentations of gallstones because it can lead to cholangitis, pancreatitis, or jaundice. So it's not a logical thing to do. I would not advise it at all. I don't think it works, and I wouldn't advise it.
Thank you. Another person has asked, is ERCP the same as keyhole surgery?
No, so keyhole surgery is a general anesthetic. It's an operation that I do with the 4 small cuts that I showed you on the diagram to go inside the tummy cavity and peel the gallbladder from the liver and take it out of the body. And ERCP is a special camera that goes down the mouth into the gullet, stomach, and into the first part of the bowel. And it can access the lower end of the common bile duct, the main channel, to move any stones, to trap any stones and bring them out the bottom end, or to make a cut in the muscle to allow stones to drain through, or to put a stent, a tube up into the common bile duct. So it's a minimally invasive procedure, it's not surgery, and it's only designed to deal with common bile duct stones, not the gallbladder.
Great, thank you. Someone has asked, what does sludge mean, and is it dangerous?
So the very early stages of stone formation, if you think about it, you have to have a nidus, a very small little piece of mud, gravel, or crystal. And so if you're forming gallstones, and that's, they do an ultrasound scan at the very beginning of you having and forming gallstones, that's what they will find. They will call it mud or gravel or sand in your gallbladder. It doesn't look like stones. What it looks like is a sediment almost that lies and gravitates towards the bottom of the gallbladder. So that's what they're suggesting, sludge. And some people will say, well, actually, I'm not going to treat sludge. I'm going to wait until it forms stones, proper stones, bigger stones. But some people will say, well, actually, you're going to have stones anyway, so why not treat it there and then?
Great, thank you. Someone's asked, what's the criteria for deciding between keyhole surgery and open surgery?
Because keyhole surgery has become the gold standard for performing gallbladder operations now, I think you would struggle to find a surgeon in the UK or possibly anywhere in Europe that would do an open procedure to start off with. So we always start with keyhole. So in other words, we're attempting it with keyhole. But we know that there is probably a 5%, 10% chance that we need to do an open cut in some people because of the complexity of their presentation. So we then convert to an open procedure. It is quite possible that's, because of, remember we talked about the person who had a radical nephrectomy before, so a big scar to take out the kidney on the right-hand side. It may be possible that you look at their tummy and you think, well, you know what, I'm never ever going to be able to do keyhole surgery here. So I'm going to start with open surgery. But the gold standard is you start with a keyhole operation, then you convert to an open operation. A very small percentage of people will need an open operation from the start.
Great, thank you. We've had a couple of people ask about recommendations for diet, nutrition, any supplements they could take that would reduce the effects of gallstones.
So gallstones are not necessarily related to any nutritional deficiencies, apart from the fact that you perhaps maybe not able to digest fat as well as you should do. So a general multivitamin would probably cover you for things like vitamin K, etc. But generally, we don't tend to recommend multivitamins for people with gallstones unless you take them, as a standard.
Great, thank you. And I think we have one of potentially your previous patients on here, and they've asked, I think they asked the previous question about the mesh because they had a hernia. And they're saying if they had surgery, would a third mesh need to be installed?
So this is where we've done the gallbladder procedure, punctured a hole through the mesh, and at the end of the operation, we stitch that hole as well as we can. But then we're speculating that the person has had a recurrence of the hernia in that position. Then again, this is all speculative, and it doesn't necessarily mean that you need to have a further hernia, present or repaired. But if that was the case, in the worst case scenario, you have another hernia after you've had 2 previous mesh repairs, then it's very likely that you will need another mesh repair for your hernia.
Great, thank you. Someone's asked that they've had a CT scan showing stones in the gallbladder, and they're a bit worried waiting for results of their MRI because they've still got pain in their stomach. Should they be worried while they're waiting for the results?
I don't think so. I think that, depending on your presentation, how your gallstones have presented, if it's biliary colic again, where it's just pain and discomfort related to meals, then you're quite safe. If you've had cholecystitis before and you've been to hospital for IV fluids and antibiotics, then of course, you know that there could be another attack. So I would stick to painkillers and low-fat diet. If you've had a stone pass through, and you're waiting for an MRCP, then you probably need to have an ERSP soon after if they do discover that there's a stone in the common bile duct. So it really depends on the presentation. But generally, most people with gallstones are quite safe to wait a bit longer.
Great, thank you. Someone has mentioned a medicine called Usodiol. They're wondering if that's available in the UK, if that's something that we would potentially use, and does it break up the stones?
So I think they're referring to ursodeoxycholic acid, which is the scientific name for it. And I think it is available, but it may need to be prescribed. And again, I go back to what I said before, which is I do not believe that breaking down gallstones is either safe, effective, or necessary. You're only trying to make the stone smaller. That puts you at a higher risk of the stone slipping into the main channel and causing even further trouble. And I don't think that the medication actually does work.
Great, thank you. I've got a last question here. What could be done if someone is too weak to have an operation for gallstones?
Yes, and sometimes that happens. Some people are quite frail and weak to have a general anesthetic, to have surgery. And if that's the case, then what we sometimes decide to do is do an ERCP and create a sphincterotomy, which is to nick the bottom part of the bile duct, so that in the unlucky event that a stone were to slip into the main channel, it would just pass through the bottom end and not cause the more serious presentations of gallstones, such as cholangitis, pancreatitis, or jaundice, which I talked about previously. So really, that would be probably the definitive management. There's another way of managing gallbladder problems, especially cholecystitis, which is putting a drain through the skin into the gallbladder. That's called a cholecystostomy tube, and that drains any pus that may be in the gallbladder to help the inflammation settle. And again, we use that if we can't do an operation in hospital.
Great, thank you. And that looks like all the questions that we've had come through. But if we didn't answer your question, we'll do so after the event if you've provided your name. And if you'd like to book a consultation with Mr. Hamouda or anyone at the hospital, our private patient team are available to take your calls, and that's between 8 AM and 6 PM Monday to Friday. And that's with the contact details on the screen. We're offering a small discount for this session, and that's with the terms at the bottom of the screen, so that'll be 50% off your initial consultation. You'll receive a short survey at the end of this as well. We'd be really grateful if you could spare a few minutes, just so we can have your feedback, and it helps us put on future events and see what topics and things you'd be interested in. Our next webinars include hip and knee surgery and cataract treatment, and you can visit our website to sign up for those. So on behalf of our team at Benenden Hospital and Mr. Hamouda, I'd like to say thank you for joining us today and hope you have a good evening. Thank you and goodbye.